This conference will now be recorded.
Thank you. Hello. Am I audible? Hello.
Yes,
Hello.
sir.
Yeah. Shall we start? Is everybody there?
50 members వచ్చారు సార్
50 na? Wait చేద్దామా 2 minutes sir?
yes sir.
Okay. 53. Okay, today's topic anyway is చిన్నదే లేండి. It's a small one. Okay, first things first. Everybody is messaging present. In 2 minutes we'll start. Okay, in 2 minutes. Okay, let people. Okay, shall we start? Okay. It's almost 100. We'll start. Okay. Hello. Good morning, all. Good morning, all. Hope
Good morning, sir.
audible. Yeah. Good. Thank you. Yeah. Hope you're all staying safe. Yeah. Today's topic is upper respiratory tract infection. Okay, this is a relatively smaller topic, and it's more of practical than of any theoretical value. Because as a pediatrician or a physician, we are day in and day out, we'll be seeing a lot of cases of respiratory tract infections. Almost the main crux of your OP or your practice will be of respiratory tract infections. Okay, even for pediatrics and adults, it is the most common. Okay, now coming to the upper respiratory tract infection, it is the upper respiratory tract. So there must be something like lower and upper respiratory tract. So what demarcates is, it's a theoretical than a most of anatomical thing. The structures above the thorax is upper respiratory tract. In upper respiratory tract they are considered, and below the thorax, some book says that it is the glottis that marks the demarcation and differentiation of upper and lower. But usually theoretically we can consider even the initial few segments of trachea also as an upper respiratory tract. That is the reason why we include croup. Okay, tracheolaryngotracheitis, we include that also in upper respiratory tract. Okay, yeah. With this brief introduction we'll go. Yes, see, upper respiratory tract infections are the most common illness to affect children worldwide. That is the most common anyway. Most children experience one or more of these episodes per year, and at an average, this is the AAP, that is American standards. It is 6 to 8 per year, but in tropical and countries like us, we may have 10 per year also. Okay, even those are normal. Okay, the frequency of infection varies with season, obviously, as we all know, with rainy season and a colder atmosphere, we can get it. And infections are more common in autumn and winter in temperate regions, and in rainy in tropical regions. Autumn is something that which comes after the summer, and the winter, the colder climatic conditions. Okay, the mode of transmission varies according to the viruses. Okay, mostly it is respiratory. Okay, droplet infection, droplet and fomite transmissions. Okay, mostly the infections are viral. Bacterial are not so frequent. It is mostly the viral. Okay, whenever we say that it is upper respiratory infection, it is mostly viral. Up to 80% to 90% it is viral. Only few are bacterial, and which can be very serious if it is bacterial. Okay, spread by droplet or direct hand to hand fomite and all these things which we can day in and day out hear from the caller tune. Okay, and it is more common in crowded conditions. Okay, now we'll be discussing about few of the actual diseases, okay, of upper respiratory tract infections. Okay, very small and concise discussion of every in detail. The first thing is rhinosinusitis. As the name imparts, it is rhino and also the sinuses, the nose and also the sinus. Okay, the nasal part of the respiratory mucosa is affected. Okay, and the respiratory mucosa, remember these terms are important because the receptors and the holding areas of the virus is the respiratory mucosa. Okay, common virus include rhino, corona, and respiratory syncytial virus and metapneumoviruses. Okay, the mean number of viral colds are around 5 per year. This is Western standards, and we may have up to 10 per year also. Okay, the mean duration of symptoms is 8 to 10 days, but can last beyond 14 days. That is 2 weeks. Okay, like you just imagine the coronavirus and you can understand it better. Actually, this 2 weeks period, 8 days, and all these are common for most of the viral illnesses. Okay, symptoms include nasal congestion because there is infection to the nasal mucosa. Mucosa is congested. Rhinorrhea because there is inflammation. There is more secretion of the mucus into the nasal cavity, and cough because of the irritation, and sore throat, the same thing, because the mucosa is affected. It gives you a rough and sore throat, and fever, of course. Okay, rhinosinusitis is usually a self-limiting illness because most of the viruses they come and they go by their own, and they are self-limiting, and nothing much we can do. It is only the supportive management we can give, and if it gets serious, it gets pretty serious, and medications are still under trials. Only few established viruses has medication. Other than that, everything is supportive. We'll just wait for itself to come down. Okay, in the absence of any other worrying feature, history and physical examination, isolation of the case, all the same thing with the corona thing. Recurrent viral loads do not require further investigations. Just only if at all, if there is more episodes or the duration is more, only then we should, something has to be kept in mind that maybe we are losing the control on the disease, and maybe the child is getting sicker. Okay, it is more than 15 episodes per year. See, up to 10 it is okay, accepted, everybody will have, but if it is more than 15, then we should think of investigating or looking into the child. And the duration is, if it is more than 2 weeks, that is more than 15 days, again it is important to look into the cause of the disease and which way the graph is going, how the child is progressing or deteriorating. Okay, in up to 0.5 to 5% of cases, common colds become complicated but the development of by the development of acute sinusitis. See, rhinosinusitis can go into acute sinusitis. Okay, the next level of involvement. See, the upper airway, just imagine by anatomically, there is a nose, there is sinuses beside the nasal cavity, and there is nasopharynx, oropharynx, that is the pharynx, and then goes through the larynx, and through the glottis it goes to the trachea. Okay, now we are going accordingly. Okay, now the rhino part is over, the nose is over. Now we are going into the sinusitis, because rhinosinusitis can complicate into acute sinusitis. Okay. A few definitions just to remember for academical purpose. Acute rhinosinusitis is upper respiratory tract infection that persists more than 10 days with nasal discharge, cough, and bad breath. Bad breath is because of the pooling of secretions, and if the secretions are super infected by bacteria or is any purulent secretion, you will get a bad breath. Okay. And or severe upper respiratory tract infections with fever of 1 or 2 or more and purulent nasal discharge for 3 to 4 consecutive days. Okay, it is not that now I had and 2 days I'm okay and after 5 days again the child developed. That doesn't come into acute sinusitis. It should be continuously for 3 to 4 days. And there is a term called chronic rhinosinusitis, where the indolent infection that lasts more than 3 months. See, most of in pediatrics and most of in adult diseases also, this is the mark. Okay, 3 months. If it's 3 months and above, it is usually called chronic of anything, be it liver or mostly most of them, not a hard and fast rule, but mostly if it is 3 and more, it is a chronic disease. If it is less, it is an acute or subacute things. Okay. Yeah, if it is lasts more than 3 months, it is chronic rhinosinusitis with the typical symptoms of nasal congestion, cough, and bad breath. Okay, you may face a child where the mother complains that there is always running nose, there is always bad breath from his mouth. Okay, then we should think of rhinosinusitis. Okay, now coming to the next, the things that are beside the nasal cavity, that is the sinuses. Okay, the inflammation of the sinus is sinusitis, and in children the maxillary and ethmoid sinuses are fully developed at birth, and sphenoid gets by 3 years and frontal gets by 7 to 8 years. Okay, so what is the implication is, they are formed at birth, so obviously they can be infected from birth. Okay, when the sinus is there, there is a chance of getting infected. So you may have, we should think of these things when we are dealing with a child's age. Okay, we are not supposed to think like we don't do, right? After an infant coming with chronic running nose and all stuff, we may not think of sphenoid or frontal sinusitis. We may be thinking of maxillary. Okay, yeah, these are the anatomical location. If the pointer, if it is visible, you can see the blue things is frontal, the purple ethmoid, and the big ones are maxillary. The sphenoid lies inside actually the base of skull. If you get a section, we can see the sphenoidal sinuses. Yeah, coming to the sinusitis, it is defined as the upper respiratory tract infection that affects predominantly the nasal part of the respiratory mucosa. Again, the terms are important. The nasal part of the respiratory mucosa. Okay, it can be acute as it is less than 30 days, or chronic if it is more than 30 days. Okay, that is regarding sinusitis. It usually manifests as a complication of common cold. Okay, the same thing, rhinosinusitis, that will lead into the sinuses which are quite adjacent. Okay, and the infection can easily pass. The most common causative organisms here in sinusitis, it is mostly the bacterial. Okay, rather than viral, it is bacterial infection that can mostly cause, that is Streptococcal pneumoniae, Haemophilus influenza, Moraxella, catarrhalis. Okay, the diagnosis is mostly on clinical, or if there is as the child is presenting with cough persisting beyond 10 days without improvement, worsening disease course, and severe onset with recurrent fever with purulent discharge of more than 3 days consecutive days. Okay, the same thing which we are discussing is till 2 weeks it should be normal. If it is going beyond 2 weeks, if the graph of the child is going worsening, it is not improving, and these are the things we should think of when we are dealing with the disease. Okay, and analgesics are helpful to control pain and fever. Antibiotics are not commonly used. Only if you think of absolute bacterial etiology, then you can deal with it, because as we discussed, most of the thing is rhinosinusitis and the cause is viral mostly. So the role of antibiotics is not much into it. Okay, even if at all you have to give an antibiotic, you should think of amoxicillin in a higher dosage, or with clavulanic acid, okay, as the line of treatment, okay, because the most common organisms, we select an antibiotic based on the common organism being Streptococcus, Moraxella thing. So we may have to give a penicillin drug, that is amoxicillin, okay. The complications are rare but include meningitis. Here it is important because the sinuses are wide space and mucosa is affected. If at all it goes bad, it goes bad very bad, okay. Meningitis, direct the mucosal surface, and it goes into the venous, and it can go into meninges, that is meningitis, or it is can go into cavernous venous thrombosis and orbital cellulitis, the surrounding areas where the mucosa is intact or being connected, the infection can pass, okay. This is CT, okay. This is a transverse section of a CT, just showing you the left A is the maxillary sinuses. Here you can see the level. If the pointer is visible, you can see this. The black is normal, black is air. It has to be black, but at the undersurface you can see that there is white graying of the area. That is your enlarged sinuses, sinus mucosa because of infection. This is maxillary sinusitis, okay. And here B, you can see the arrow, and it is the ethmoidal sinuses. It is the ethmoidal sinus which is completely obliterating the sinus, which has to be black as it is on the right side. The left is completely blocked up, okay. It has to be black because air has to be there in the sinus normally, okay. Now coming down into the tract, now it is the pharynx that happens, okay. It is the pharyngitis. This is the most important regarding infections, because pharyngitis, and where the in that cavity we can see the tonsils also. It is mostly pharyngotonsillitis or pharyngitis, okay. They both go in hand, okay. Yeah. Pharyngitis is the acute respiratory infection that affects the respiratory mucosa of the throat, okay. A step beyond, okay. From the sinuses and nasal mucosa, now we are coming down. It is the pharyngitis, and children of any age can develop pharyngitis and tonsillitis. As we discussed, it is hand in hand, pharynx and also the tonsils, okay. The etiologic origin may be either viral or bacterial, and it is difficult to distinguish between these two, okay. There are few clinical markers of differentiation because between acute viral pharyngitis and acute bacterial pharyngitis, but most of them will have an interlacing mechanism, like interlaced. The symptoms, they don't they are not so specific for viral and so specific for bacterial, apart from acute onsets and rapid deteriorations, okay. Where we can see high fevers can be seen in viral, and if it had it been a bacterial infection, you will have a in more relatively an indolent phase. It is not a struck and straight forward uh, fever and malaise and all stuff like in viral, okay. That is how clinically we differentiate, but mostly uh, differentiation is pretty difficult, okay. A throat swab is necessary to determine the presence of streptococcal pyogenesis, because this is of interest, because if it is a streptococcal infection, that is there is a rapid kit you can kit. It is not it is not available here in our place, but a rapid diagnostic kit will be available. You can just scrape the swab from the throat, and you can get a test done for streptococcus, because if it is streptococcus, you may have to hit with an antibiotic and early, okay, because particularly in pediatrics, that may lead to rheumatic and other diseases, okay. And coming to the mostly how it presents, it is pharyngeal exudates will be there. There will be a lot of secretions, the postnasal drip, there is whitish layer, and whenever you're looking at the throat, throat examination, you will have red, beefy, and congested picture, okay. The cervical, draining cervical lymph nodes will be enlarged, and they'll be painful, and there will be history of exposure of a streptococcal infection nearby, okay. And the symptoms may include pain, headache, fever, and malaise, as we discussed. And analgesics are beneficial for pain, and mostly, and antibiotics if you are thinking of a bacterial process. Okay, and penicillins are the penicillin. It is the drug for Streptococcus even now, and most children with viral etiologies origin will improve spontaneously, as we discussed. Viral, mostly self-limiting, and it gets better by 2 weeks, that is 14 days. Complications are not most, they're uncommon because relatively throat is expected to be having a much of wide uh, infection around. That is the reason why we are being provided with the Waldier's ring and the tonsils and everything in the in and around the mouth, because it will usually protect the infection. So the complications are not so common in case of pharyngeo tonsillitis. Okay, but if at all something is happening, we can should think of any peritonsillar abscess, otitis media, because the infection can pass through the eustachian tube, which is also is coated by respiratory mucosa and has connection into the middle ear, so you can get acute otitis media. And acute sinusitis, of course, it can go up, and rheumatic fever, as we discussed, and acute glomerulonephritis because of the notorious streptococcus. Yeah, this is how it usually presents. See the red swollen, the uvula is swollen. Here you can see it better. Uvula is swollen, and they can be exudates. Okay, this whitish exudates. Okay, and even diphtheria also can present like this, with a membranous infectious mononucleosis can present with high fevers, lymphadenopathy. All these are comes under etiologies of pharyngitis and pharyngotonsillitis. Okay, now coming to the now we have seen diagnosed and everything. Now the management, if at all we are thinking of a bacterial etiology like a gas, that is group A streptococcus, penicillin is the choice. See, plain penicillin can be given 250 mg BD or TID for 10 days. See here, it is very important, the duration is 10 days. Okay, it's not like 5 days or something we give for any other infection as widely being used. Okay, plain penicillin, nowadays not many people are using it, but still it holds good. Okay, the tablet Pentids comes. Okay, and amoxicillin, now it is the widely used. It is of 50 mg per kg in a day. Actually, it is 40 to 80 mg per kg now, averaging it to somewhere around 50. The duration is 6 days. Okay, duration is also important. Okay, because to eradicate it is not like incomplete like 3 days or 5 days, it is 6 days. And intramuscular benzyl penicillin, because as a single dose you can do it. It lasts for 3 weeks to 4 weeks. Okay, if you are giving a single dose of intramuscular, that is the advantage and all, but the injection is very painful. Okay, that is the side effect as a single dose. Okay, remember, as a single dose, dosage is, if it is less than 27 or 21 kgs in few demarcation, it is 6 lakhs, and 27 and above it is 12 lakhs. But if at all the child is penicillin allergic, erythromycin in a dose of 40 mg per kg per day, duration is the same, 10 days. Okay, cephalosporins and macrolides like azithromycin, clindamycin, and all this can be used. Okay, but they are not usually recommended, and penicillin is the drug. Okay, now coming to the, now infection has our infection has surpassed pharynx, and now it has passed into the close proximities, like through the eustachian tube into the otitis media. And this is important in case of kids. Okay, in infants it is very much important, because the eustachian tube is relatively more horizontal, and it is more connected to the middle ear than in an adult, relatively adult, because relatively in adults there is more angulated, and there will be a valve like mechanism, so that the infection not easily pass into the eustachian tube and into the ear. But in kids, where in infants where they are mostly horizontal in position, they can't stand up or sit up to 6 to 8 months, so they're mostly lying down in posture, so the infection from the pharynx, they can easily go into the middle ear. Okay, that is how we have to think of otitis media. Otitis media is an acute respiratory infection that affects the mucus of the middle ear. Okay, the mucosa passes from the pharynx, nasopharynx, and this thing we use taking tube into the middle ear. Open up. I think you are fresh from you're dealing ENT. I think you must be well versed with the anatomy and connections. Yeah, it is more common in young children, as we discussed. They have the disadvantage of anatomy. They're more horizontally placed, so more common in young. Peak is 6 to 12 months, as we discussed. Mostly they lie down, and infection can pass easily. And 6 till 6 months, they'll be well protected with the maternal antibodies. And after 6 months, the complementary feed starts. Okay, yeah, the etiology origin may be mostly, as we discussed, it is viral, and only a few cases it is bacterial. Okay, diagnosis should not be assigned unless there is bulging or fullness of the tympanic membrane. Otoscopy is one armatorium, one arm should be having for a pediatrician. Okay, assigned until there is bulging or fullness of the tympanic membrane associated with middle ear effusion, and if the tympanic membrane is opaque looking and it is bulged, and in few cases it may be ruptured also. And as we see, because as we think of, if it is red, in if the tympanic membrane is should be like a pale grayish pale thing. If it is red, that is not equal to otitis media. It may be because of any other infection, or any blow can cause redness, or any foreign body, or any external meddling with any birds or something that can cause redness. Redness alone is not a sign of otitis media. Just remember this thing. And the management, if you're thinking of a bacterial, high dose amoxicillin or amoxicillin can be used. The same thing goes with the same dosages as we discussed. And the duration of the treatment depends on the age and severity. Most obviously it is mostly viral, so mostly gets by 14 days. The same song is being sung, right? 14 days viral, mostly amoxicillin, penicillin. The same thing for all respiratory tract infections. The complications are uncommon. Okay, mostly it heals by itself. Okay, otitis media, it itself is like a mostly a complication. Just remember, the only sinusitis has a very bad thing, like it can go into the meninges or cavernous sinus thrombosis, where it can go pretty bad. But other things, they're relatively okay with the less complications. Yeah, regarding the management, as we discussed, less than 6 months, don't think it is like, be on a more cautious side. Think of more bacterial, and try to have a more pro into using antibiotics less than 6 months. Okay, don't wait much thinking of it to be a viral, because the immunity issues, and the child is relatively not much immunized by the age of less than 6 months. And 6 months to 2 years, yes, you can think of, if at all it is, if you're thinking of bacterial, you can go for antibiotics. And if it is more than 2 years, where you have given full doses of your immunization, and the child, we are expecting the child to be more fighting back with the antibodies that have been produced, we can wait on, and we can see. If at all, if you think if it is bacterial, always do an antibiotics. Okay, yeah. The next thing is relatively more severe part of our topic. It is the croup. It is laryngobronchitis, laryngitis, all the stuff. It is most commonly called as croup. Croup is a group of disorders. Like, it is a spectrum of diseases, like laryngitis, laryngotracheitis, laryngotrachobronchitis. Everything are grouped under a single term, croup. Okay, croup can be anything. Okay. Croup causes swelling and inflammation of the larynx and the trachea. Okay, we are down into the anatomy. It is larynx and trachea. Viral croup has the common thing. Viral is common, bacterial is rare. Okay. Peak age of incidence is 6 months to 5 years, because that is the period where they start roaming around, and as more roaming, they can contract more infections. Okay, para-influenza viruses are most common. Influenza, para-influenza are the most common causes of croup. And viral croup typically manifests with see, the presentation is very classical. Okay, that is the here comes the importance of history taking. Okay, the presentation is acute. It is sudden onset of barky cough. Stridor is a very bad sign, and it is an emergency for any pediatrician. Okay, when the child is having stridor, that is bad to hear. Okay, and you need to be very fast in managing the child. And respiratory distress, you can see that labored breathing and abnormal breathing patterns. Okay, in a setting of coryzal infection, that is rhinitis and other common cold issues. Okay, see, the presentation is so dramatic. There is sudden onset of barky cough. The nature of cough is barky, and stridor is both inspiratory and expiratory, mostly the inspiratory stridor will be there. Okay, hope you know what is stridor. Okay, that is stridor. Okay, when somebody comes with stridor, that is bad. Yeah, infections are seldom, sorry, investigations are uh, not necessary, because by the moment you see stridor, sudden onset barky cough, you think of a group or viral infection mostly. So there is nothing much you can do with investigations. However, X-ray of neck and chest is needed to see, and treatment is mostly symptomatic. You first thing, in case of pediatrics group, the most important thing is keep the child with the mother, calm the child, don't be more invasive to the child, don't be very aggressive, and try for venous line. If it is difficult, just wait. If the child is well hydrated and all, just wait, make the child calm, because with exertion, stridor increases, obstruction increases, and respiratory distress increases. So in maintaining the child is keep the child with the mother, because mostly they are less than 5 years. They will be apprehensive, they'll be hungry for breath. Okay, don't try to give aggressive management in and around the child. Don't try to upset the child. See the comforts of the child. Okay, and then manage. That is equally important. Okay, and now treatment is yeah, like always, you do supportive management. If the stridor is bad and serious, you need to secure the airway. Securing the airways, you may have to intubate or nebulize. Oh, okay. And here group can be mild, moderate, severe based on the severity. And if it is mild and moderate, we can deal with the oral corticosteroids, where this is a new drug has come now. I mean, we are dealing with amoxicillin, penicillins, and supportive management. Corticosteroids, importance is at the group. Okay, laryngitis and tracheitis. Oral corticosteroids and racemic epinephrine nebulizations you can give. This is important, racemic, because that it is normal epinephrine, that is adrenaline, but racemic is, it is a mixture of levo and dextro. It is 1:1. That is technicality of the adrenaline. The studies found that they are more effective than normal levo adrenaline that is usually available. That is why racemic epinephrine. Okay, here the treatment has slightly changed. In now oral corticosteroids have come because to decrease the inflammation, because there is narrowing of the airway due to enlargement of the mucosa. Okay, so we're decreasing the inflammation, we may have to use corticosteroids. So we decrease the inflammation so that the edema decreases, so it improves the air in and air out. Okay, that is the rationale. And epinephrine, being a vasoconstrictor, also does the same job. Okay, decrease the edema and help us to secure the airway. Okay, here is the famous stipple sign. You can see the arrow mark, stipple. Okay, the pointed thing. Yeah, you can see. Okay, this is the first. A is the lateral X-ray and B is the AP. Okay, the sharp thing. Okay, this is not so classic. It's nothing like, if it is there, it means that there is a group. It can be there in normal variants up to 30%, and even in group it may not be much evident. But just think of this, because for entrance and other importance. Now the infection has started. See the epiglottis, which covers the airway. because we know that, right? The larynx, trachea, sorry, yeah, but at the larynx it can be from esophagus, airway, and the foodway, and this is the epiglottis, which covers the airway and protects from aspirations. Okay, now if it gets inflamed and if it gets infected, okay, that is epiglottitis. So and this is pretty serious. Now we're doing serious job. Epiglottitis is very serious infection of the epiglottis and the supraepiglottic structure that result in acute airway obstruction and high risk of death. Okay, and this is because it is again to do with the anatomy of the pediatrics and anatomy of the adults. Anatomy of pediatrics, the airway is more conical and more cylindrical in case of adults. So when it is conical, you can imagine like it is a funnel like thing, and the lower part, which is more narrowed, if it gets obstructed, it gets pretty bad. Like it is common sense. If the narrow parts gets even more narrowed, it gets serious. This is what happens. Like epiglottitis, if it gets involved, it will result in very bad presentation. Acute airway obstruction will be there, and the child will be unable to breathe in, and there can be it may go bad, as bad as the child can. We may lose the child because of epiglottitis. Okay. Fortunately, it is very rare these days because the most common, I mean, not most, usually it is caused by H influenza type B, and we are left and right immunizing the children with the influenza vaccine. So the incidence has come down. And onset is typically abrupt, as we discussed. It is very sudden with the sore throat, if the child can tell. Okay, and difficulty swallowing, respiratory distress, drooling, because the airways are there swollen in, so it will be very difficult to swallow even the saliva, so they start drooling the saliva out. And choking sensation, irritability, the child doesn't know what is happening. The child will be having very difficult to push the air into the lungs with a narrowed airway. So child will be very restless, irritable, doesn't eat, will be cranky, anxious, sweating. Okay, this is how they present, because then we may have to think of any epiglottitis that is happening. Okay, mostly, yeah. Diagnosis is by direct visualization. You can see the epiglottis swollen and like a big mass that is obstructing the airway, but don't try to do it as a regular process, because as we discussed it in group, it is the same thing. That you should keep the child at ease with the mother, and don't try to examine the child aggressively, because we may induce sudden respiratory obstruction and the case going bad and sick. Okay, so direct visualization can be there, but don't usually try. Leave it to the experts like ENT and anesthesians. Don't try to see. And airway examination should be considered only after airway is secured. Okay, the same thing. Okay, you may have to secure it with a laryngeal mask, or a laryngeal mask may not be much effective, but you may have to secure with a intubation, and intubation can be difficult because the airway is swollen up there. Okay, you may have to go for a tracheostomy, emergency tracheostomy also. Okay, that should be kept in mind, because it will bypass the upper airway obstruction. Emergency tracheostomy. Okay, broad spectrum antibiotic, because as we discussed, it is H influenza. Hit with an antibiotic. Ceftriaxone and cefotaxime should be initiated if there is any strong suspicion. Okay, don't, we may not have to wait for it because time is short, and we may have to act aggressively. Treat with antibiotics. This is the classic thumb sign. As you can see thumb sign, you imagine that like your hand is like this, and this is the thumb that is protruding. Oh, sorry, yeah. Imagine that the hand is there and this is the thumb. Okay, this is the thumb sign. It is the lateral x-ray that shows your thumb sign. Okay, this is the epiglottis that has been that has been blocking the airway. Okay, it is blocking the airway completely. Okay, this is the swollen epiglottis. Yeah. Now coming down to the tract, it is the tracheitis, the trachea is affected. That is bacterial tracheitis. See, mostly the croup we covered it, the viral. Mostly the croup is covered by viral. That is uh, tracheitis. Now coming to the bacterial tracheitis, there is infection and inflammation of the trachea, as the name suggests, and it is uncommon but potentially dangerous. Bacteria not so common as we discussed, and it is characterized by thick membranous tracheal secretions that obstruct the airway. Okay, the same bad news. Mucosa getting affected. Mucosa, if it gets affected, it gets swollen, edema, and it will pour in more secretions. And once the secretions are getting more and more, they get thick, dried up, and they will cause mechanical obstruction through the airway. And trachea is the only way that it can pass, because see, if it is had it been a nose or sinus, they are not sick because you can breathe through mouth. You can there are other lot of cavity that can pass through. But just imagine when there is only way and that is getting blocked, that goes bad. Okay, that is what happens with epiglottis, tracheitis. Okay, that is why they are more sicker than the upper, more upper involvement. Similar to viral group, the age group is mostly 6 to 5 years, and mean age is 4 years. And the staph aureus is the most notorious, causing bacterial tracheitis. Okay, as such, tracheitis is viral, but bacterial tracheitis is by staph. Okay, prodrome or upper respiratory tract symptoms precede the progression of severe obstruction. Like you may have all these involvement like malaise, fever, difficult to breathe, cranky child, respiratory distress, all can be there, and then it may go bad. Okay, a lot of secretions coming out from the mouth and nose. Okay, definitive diagnosis is by bronchoscopy. Only then you put a scope into the trachea and you see the swollen thick secretions, red beefy thing, and that all. That is the definitive diagnosis. But bronchoscopy in child with a compromised should be done with caution. Okay, most children will need intubation and started by antibiotic, as we discussed. If it is bacterial, we may have to start antibiotic as early as possible. Okay, don't wait for the symptoms to get worsen. Okay, yeah, this concludes the upper respiratory tract as we went into the trachea. Okay, from trachea down, from the initial part of trachea down, it is the lower respiratory tract, and the infections are totally different from the upper respiratory tract. Okay, this is the conclusion of the class, and yeah, is everything okay? Hello, can somebody can respond?
Yes, sir.
Yeah, okay, thank you. Any doubts? I think we have some time, 10 minutes or so. Any doubts, anybody? Is it audible, clear?
Yes, sir. It was clear, sir.
And then it is understandable?
Yes, sir.
At least, yeah, if it's,
Yes.
even if it is
Yes.
yeah, good, good. Uh, any doubt you can type in. I think you will have a chat to ask. If you want to ask any doubt, you can ask, or we can conclude as well. Okay, okay, shall we conclude then? Hello.
Okay, sir.
Yeah, yeah, okay,
Yes, sir.
okay, thank you all for your patient hearing. Be
Thank
safe. Okay, yeah, bye bye. Bye.
you. Thank you, sir.
Thank you.